Hi, everyone, and welcome to today's Health for the World International Grand Rounds lecture on pediatric sports medicine and overuse injuries. I'm Dr. Sedinam Adamale, a radiology resident at the Kolebu Teaching Hospital in Accra, Ghana. It's my pleasure to introduce our distinguished speaker, Prof. David Swenson, Vice Chair of Quality and Clinical Operations and Associate Professor at Brown University Warren Alpert Medical School. Prof. Swenson is a renowned pediatric radiologist with expertise in pediatric musculoskeletal and emergency radiology. Today, he'll share his valuable insights on pediatric sports medicine and overuse injuries. Please join me in welcoming Prof. Swenson. Kindly note that you are invited to share your location and ask questions in the chat box. Prof. Swenson will address all your questions after the lecture. I'll now hand over to Prof. Swenson to start. Thank you.
Okay, thank you very much. All right, so there may be a little bit of background noise as our lecture, we still have a few of our residents trickling in, but I'm going to get started and take it a little bit slow at the beginning, talking about some of the background and epidemiology of sports medicine and overuse injuries. And then we'll get into cases, which is more of the meat of the lecture and discussion. And then as was mentioned, I'll be happy to try as best I can to answer any questions that may arise at the end of the lecture. Okay. So by way of background, first of all, I have no disclosures that are relevant. Simone Biles, I hope everybody knows, is a phenomenal gymnast. She's probably my favorite athlete in the world. I don't know of anybody who performs at quite such a high level that is just so far above all the competition. So I remember the first time I watched a YouTube video of a Simone Biles floor routine, and I was just kind of astounded, and I watched it like 20 times in a row. So I like to think of her as sort of the epitome example of a high-level athlete on the international level who does incredible feats of athletic performance, and which clearly does, requires an incredible dedication to repetitive training. And repetitive training is the essence of sports injuries and overuse injury patterns. So you have to have quite a bit of resilience to perform sports at a high level. By way of connection, all of the images in this lecture are either open source, available freely online from open source resources, or the imaging examples come from my own imaging teaching files. So this is an example of artwork that was actually part of the 1928 Olympics as part of the Olympic art competition, which I just think is fascinating. That there was, when they were first starting to kind of re-establish international Olympic competitions in the early 1900s, they were really sort of grasping at straws, trying to figure out what exactly comprises a sport or a competitive field of endeavor that is worthy of international competition. And so this was a painting that was entered as part of that international competition, and it shows some rugby players, which is a fairly international sport. But I just like that it kind of has a mixture of art and sport. And the next image here brings together my own family. This is my oldest son when he was younger, but I love that he has a tiger shirt on and that he is aggressively sprinting and almost the same exact position as this rugby player from 1928 in the painting. And he's sweating profusely. You can see all of that on his hair. This is all natural sweat from my little son in New England in the summer. And you can see how hypertrophied his forearm muscles are here. At that time, he was quite well and trying really hard. And as an American parent, sports is a huge part of our lives, and we like to live our second childhood through our own children. And so, especially in American culture, there's a lot of pressure on children to become athletes and to become high-level athletes. And that will play into a little bit of the epidemiology of overuse injuries in sports medicine that we'll be talking about. So I am not, I am part of the problem. I'd like to believe I'm part of the solution on the medical side, but I am also part of the problem because I see this picture of my son and it gives me great pride, right? He's sweating, he's giving his all, and this is before he's even old enough to actually be engaging in team sports. So, all right. This is from an article from 2015, but Bruce Reiter is an orthopedic surgeon in Chicago. And this was just an article where he described a common scenario that he experiences as a sports medicine and orthopedic surgeon specialist, dealing with a lot of high-level college athletes at the University of Chicago and other universities in the area where he practices. And so he describes having a high-level runner come in, and he says to them specifically, you know, I think you may have a stress fracture brewing somewhere in your femur. I know there's an important meet or an important competition coming up this weekend. But before you participate in that, I really want to do some sensitive radiology imaging. I want to make sure that we know how bad the stress fracture is, because we may want you to rest. And then he says that the response he gets from the athlete is, you can do whatever thing you want. You order any test you want. I'm running in the meet, right? There's no chance that this athlete is going to give up on an opportunity to compete on the weekend following this interaction, right? So he gets the imaging. And here is a nuclear medicine exam, so nuclear scintigraphy bone scan. And you can see there's an arrow pointing to a region of increased uptake in the right femoral neck, kind of basicervical region. It's a very common location for femoral neck stress fractures. And not that the resolution is great, but you can get a sense that that signal increase is traversing basically the majority of the femoral neck, right? It's not just a little bit at the medial side. It looks like it kind of goes across the entirety of the femoral neck. So that would be a high-grade stress injury at pretty high risk of actually fracturing through and causing problems, okay? So I have an opening case, and what we're gonna do is for purposes of getting through the cases, I will have you guys take some of these in the audience, but I'm gonna read through quickly the important parts of the history, okay? And then I may provide a little bit of faster guidance than I otherwise would if we were not sharing this with the world, with multiple other teaching hospitals. So here we go. Opening case, keeping in mind the prior one. 17-year-old female multi-sport athlete, 2 months of right hip pain, cross-country running. Hasn't gotten better with rest. Now, when you have rest described by a high-level athlete, then you have to take that with very large grains of salt, right? They may not be performing or practicing at the level they usually do, but that may not be rest in the same context as many of us might say resting. There were x-rays performed elsewhere and they were read as negative, and then an MRI is performed. So can I have somebody from the audience take this case and speak up please loudly so that we can hear? How about Thad, since you don't have anything in your mouth?
Okay. So it looks like we have a coronal T2
Okay.
set.
Yep.
Through the right proximal femur, right hip. I think I see some like increased hyperintense signal in the right proximal femur, kind of femoral neck, and then question maybe like some cortical irregularity at the medial aspect of it.
Okay, good. Yep, kind of right here. So we're saying we're seeing right signal or edema signal throughout the femoral neck. It seems to be most prominent at the base of the femoral neck. And then there's this little area right here that's maybe some cortical irregularity or a little band of, you could say maybe it's a band of sclerosis. If we had the x-rays, we might disagree with the prior read, or maybe they were normal, but now they wouldn't be at the time of the MRI. There might've been a few weeks in the interval. But we're worried about this, right? And so we've got all of this edema signal. It's clearly a stress fracture injury. And there's that little band of sclerosis again. It's traversing basically the majority of the femoral neck, right? All the way from the compressive side to the extensile or tensile side. And so that's going to be high risk. And so what do? In this case, they actually prophylactically pinned it, right? This is such a high level athlete and they're unwilling to rest. They pinned this so as to prevent an actual completion fracture, which they will do occasionally based on a variety of risk factors and whatnot. So I don't know exactly when the orthopedic surgeon is going to pull that trigger, but I've seen this plenty of times where they do pin it before it actually fractures all the way through, okay? Because the risks after a true fracture all the way through are considerably higher, so. All right. So this is the basic outline of our lecture today. We're going to go through some of the epidemiology and then some case examples to kind of, elucidate some of these principles. So overuse injuries and burnout in youth sports. The American Medical Society for Sports Medicine put out this position statement in 2014. There have been revisions, but the long and short is we see that there is a progressive focus on single sports, multi-season participation in single sports in America, but this also applies throughout much of the other parts of the world that have, I would say, aggressive sports participation cultures. And so, the principles, most of the literature here that I'm quoting from is coming either from America or there's a little bit from Britain, but again, the same principles apply everywhere. And so in America itself, 60 million children participate in organized sports. 44 million of them are in multiple sports, multiple seasons. Of sports injuries that are reported in the literature, somewhere around 50%, 45% are overuse or repetitive stress type injuries, and the other half are acute injuries. So you actually have a fracture, you have a discrete avulsion of a bony tubercle, you dislocate your shoulder, right? These are kind of like your standard, you tear the ACL. So this lecture today is not talking about any of those acute single episode type injuries. This is on the ones that are the repetitive overuse type injuries, okay? And in the literature, it is almost certain that overuse injuries are underreported. As anybody that's rotated with me down in pediatric radiology or MSK section would probably tell you, I love to bring out the Keats normal variant book, the tome that's like 1,000 pages thick, and point out how many of those what are described as normal variants are actually old missed injuries. Some of them acute missed injuries or avulsions, some of them are repetitive stress type injuries that maybe in the days of the mid 1900s would have manifested on x-rays only after symptoms had resolved. But now that we have more aggressive imaging and MRI imaging, we see many, many examples of these injuries that are kind of evolving over time. And sometimes they heal totally to normal, and other times they heal as bony fragments in places where tendons arise or insert. So we won't get into all of that right now. But the point is there's almost certainly an underreporting. Here's an example from Britain, University of Wales, where they just looked at about a 15 to 20 year period, and they found that the demographic trends in pediatric sports injuries in a single institution in a big city, there was a dramatic increase in the number of patients presenting to the emergency department for treatment of sports injuries. Okay, so this is, again, kind of goes along with the basic idea that they're becoming more common. Same thing applies internationally. What are the risk factors that are increasing sports injuries and overuse injuries throughout the world? Well, things that happen in childhood and adolescence that are relevant to sports injuries include growth spurts, the obvious hormonal influences of puberty, the wide range of size and age and weight between athletes participating in different sports. And we tend to band children together or adolescents together by age rather than by size and weight. And so obviously when you're playing against larger people, you're going to be at higher risk of injury, both for acute and repetitive stress injuries. In much of the world, we have a continuing and somewhat progressive obesity epidemic within our pediatric population, and that actually has a pretty significant impact on sports injuries as well. And so, the combination of an obesity epidemic that is progressively throughout the world, mixed with, varying degrees of fitness, training, proprioception, balance, et cetera, people are set up for injury. And then gender, which in some ways is kind of similar to the hormonal overlay. So hormonal influences have an impact on injury patterns, okay? And so there are some slight differences in the injury prevalence of different, between male and female based on both hormonal influence, body anatomy, and sports types of sports participation. So we'll talk a little bit about some of that. All right, so here are some examples going through. So I love this, these old anatomy pictures. So this is just the section on shoulder, bringing out the anatomy of the shoulder. And here we go. So a 13-year-old male baseball pitcher One could say this would be the same thing for American football potentially, or people playing any kind of overhead throwing type sport. Tennis, you can have similar patterns, but in America in particular, baseball pitchers are very common for this type of injury pattern. Several months of increasing shoulder pain, radiographs were called normal, and now we have an MRI several weeks after the radiographs. So who's taking our case?
So I have a couple coronal.
Yep.
Shoulder and got a T1.
Yep, we're going to say on the right is T1. On the left is maybe a T2 fat sat or something along those lines. And I'm going to draw your attention to the physis. And does it look similar medial as it does lateral? Right, I agree with that. Okay, and then on the T1 weighted sequence, which is a little bit easier to see, what about the margin of the metaphysis? Does that look any different here than over here? Yeah, slightly irregular. So we think there's a little bit brighter signal at the physis, maybe a little bit widening of the lateral physis, right? And a little bit of kind of bony cortical irregularity at that metaphyseal margin out on the lateral side, right? I'm kind of repeating the discussion here for the value and purposes of our remote audience. So I imagine it may be a little hard to hear people taking the case from the audience here. So those are the findings. And any thought on what that might mean? Anybody in the audience?
Type 1 Salter Harris.
Okay, so I'm hearing a type 1 Salter Harris type injury. So yeah, this is a physeal stress injury. Okay, and so this is a companion case because we didn't have x-rays from that prior, but this is a similar age, similar case. And you can see on the right shoulder, so left image, that there's widening of the physis in the lateral part compared to the medial part of the physis. And that's asymmetrically prominent when you compare it to the contralateral shoulder, okay? So compare that physis to this physis, and you can see that there's some sclerosis at the metaphyseal margin, and there's some bony cortical irregularity down here, and even a little bit of fragmentation at the far lateral margin of the metaphysis, okay? So this is a classic for repetitive stress injury of the proximal physis in overhead throwing athletes, and this is little league shoulder, okay? And basically it's a fatigue injury of the physis or of the kind of periphyseal bone stock, and it's related to repetitive torsional stress at the physis. And it's most common far and away, both in the literature and in my observations in practice, in young pitching athletes. So usually young males, because they tend to be the overhead pitchers. In America, we also have softball, and female softball pitchers tend to do underhand pitching. So you don't tend to see this same injury pattern in females. So I would say 9 times out of 10, this injury pattern is a young pitching male. Okay? And the treatment for that is basically rest. Case number 2 is another male pitcher. Okay, he's 17 years old, pain and sense of instability. Radiographs were called normal. Now, I don't know what, in here we have only the internal and external radiographs reportedly were called normal. So we don't have axillary view radiographs. I don't have them, and it sounds like the prior imaging was not available for axillary view, which would be relevant potentially. An MRI is performed, and so here's the MRI. Who's going to take it? Let's just go around the horn in the back row. So go ahead.
There's some hybrid signal with it.
Okay, you're saying up here? Okay, so we've got some intense signal here. And then what do you think about the morphology of the glenoid articular surface? Yeah, it looks dysplastic. All right, so there's some glenoid dysplasia here. Okay, so we have the findings here that are relevant is that the glenoid articular surface, while up front anteriorly, it has a nice kind of gentle concavity to it and slightly cupped. And so you want this to be sort of like a ball and socket joint, right? So it's slightly cupped up front. But as you get here to the posterior aspect of it, it sort of slides off, right? See, so here it's nice and sharp. Here it kind of slides down. And so there's medial downsloping of the posterior glenoid. And then we also have this signal abnormality here in the superior posterior humeral head, which is where the infraspinatus is inserting. Okay. So this is how the glenoid should look. It should be nice and flat across with a little bit of concavity. And then you should have a nice triangular labrum at the posterior aspect. And instead, on our side, it falls off. There's glenoid dysplasia. There's glenoid labral degeneration and tear. Right there. And then there's the signal abnormality here. And what this is a combination of findings. So you have glenoid dysplasia. You've got a hypertrophied posterior labrum with tearing. And then you have some insertional tendinopathy of the infraspinatus. And this happens when people have internal impingement in the setting of abduction and extension. So this again is an older high-level picture where they're repetitively hitting the infraspinatus against the glenoid rim when they're in this kind of hyperextended and abducted position in the pitching overhead throwing course of action, okay? And I would say a lot of glenoid dysplasias come from that very setting. They can be either people who are doing a lot of bench press when they're still growing and their bony acetabular or their bony glenoid has not fully ossified, or they're overhead throwing athletes. And so that ossification center is getting repetitive stress and may not fully ossify the way that it should. And that's part of that process of dysplasia. It's an active process during development. Okay. Okay. All right. This is a female, 15-year-old, 1-year shoulder pain, despite physical therapy, normal radiographs. Who's up? Okay, a coronal and sagittal oblique view. We're going to say it's T2 weighted. And is there any place with signal abnormality? Yeah, right. So that we're looking at the distal clavicle. Okay, and so here on the sagittal, we've got the acromion process, humeral head, coracoid process, and then this is the distal clavicle. And on the coronal oblique, you've got the glenoid, humeral head, and distal clavicle. And so the bright signal within the distal clavicle is what stands out. And this is, in the setting of an athlete, this is essentially going to be a chronic repetitive stress injury of the distal clavicle, okay? Which in the literature, if you look historically, is referred to as distal clavicular osteolysis syndrome. And that's basically an advanced version that may have shown up on radiographs. And so when you have a very aggressive repetitive stress injury, then what happens at the AC joint is you get subcortical microfracturing, and then the body's natural response to healing of a fracture is first to resorb the bad bone, and that is going to show up on radiographs as lysis or lucency, okay? So in really bad cases of this, if you look in textbooks or in old papers, a lot of them will show a distal clavicle that kind of fades out to lucent. And that's because these were high-level athletes that wouldn't stop, right? So what's the treatment to this? Again, the treatment to this, if you catch it early, is to stop and to let your body heal appropriately so that you don't go on to continue the fracturing and the progressive resorption of that injured bone, okay? All right, we're going to move down to the elbow. Now we have another baseball pitcher, 15 years old, chronic pain at the elbow, and worse medial swelling after throwing 2 weeks prior. X-rays elsewhere, so I don't have them. I can tell you what they show, but we're going to see the MRI, okay? Sensitive. The elbow, have the medial condyle, there's increased signal, like Yep. Right. So again, I'm repeating what we were talking here is a coronal kind of fluid sensitive or T2 weighted sequence. And at the medial aspect of the elbow, because the radius is here, so radiocapitellar is going to be lateral, and ulnohumeral articulation is going to be medial. So here we have the medial epicondylar apophysis. We see a lot of edema. The synchondrosis appears widened, and the apophyseal ossification center appears slightly displaced, and it looks like there's some periosteal or ligamentous disruption, right? So this looks like an acute injury. And you say, well, but Swenson, I thought we were talking about overuse injuries, right? This is one of my favorite cases of all time for teaching purposes because it has other findings. So now we have sagittal sequences, and what else do we see here?
Increased fluid signal in capitellum.
Mm-hmm.
Vitamin, also in the lectron. Yeah, just there. So
Yeah.
body,
A loose body, right. And so again, going back here, we have an acute injury at the medial epicondylar apophysis, which has been acutely avulsed. But if we stopped there, we'd be missing a significant part of the story. And in fact, maybe the more relevant part of the story. And so here we have a capitellar osteochondral injury, which is chronic. And here we have an intra-articular loose body, which almost certainly arose from the capitellar OCD. We have edema within the olecranon. That's an associated typical repetitive stress injury. And then surrounding this OCD free fragment, we have synovitis. Okay. And so this combination of findings, and for those that are in the remote audience, you can't see my motions as I go through the motions to try and recreate this, but this is classic for valgus extension overload. And so again, for the overhead throwing athlete, particularly high level pitchers, as they are coming around the pitching motion, at the medial side of the elbow is going to be traction or tensile stress, which we saw as the acute avulsion, but it can also be a repetitive stress with apophysitis. And then at the lateral side of the elbow is compressive. And so that's the repetitive compressive stress of the radial head on the capitellum, right? And so they tend to have medial apophyseal avulsions or stress injuries with ulnar collateral ligament tears, and they have radiocapitellar or lateral repetitive injuries at the capitellum itself, and they can go on to OCD, loose body, and joint destruction because of the loose body. And then the other thing is that this olecranon edema right here happens at full extension. So they are coming around, and when they fully extend, the olecranon is banging into the olecranon fossa, and that can result in a stress injury or stress fracture of the olecranon right here. That tends to be a transverse band of edema. And in this patient, they happen to have their OCD free fragment in the olecranon fossa with synovitis, so that would also be causing kind of an earlier impaction stress. So this case has it all, both acute and chronic. It's a classic example of valgus extension overload and has all the findings. Okay. That one needs surgery. They need to get rid of the loose body and kind of try and patch up the capitellum. This is a female gymnast, 13 years old, bilateral elbow pain. And now that we've just gone through that last case, that should make this a little bit easier. So go ahead.
Bilateral elbows on the lateral, like capitellum side, there is subchondral lucencies. On screen left, maybe you can see a defect in that cartilage.
These are OCDs both sides, right? So here we have capitellar osteochondral injuries on both sides. And so basically at the interface of the cartilage and the underlying bone, they get repetitive shearing stress that can result in chondral fissuring. And then once you have the chondral fissuring, then the joint fluid can kind of go up through the chondral fissure. And under the bony cortex, where the bone and the cartilage are interfacing, you get subcortical trabecular microfracturing. And then what does the body do when you have subcortical trabecular microfracturing? Just like with that distal clavicular osteolysis case, the body wants to heal it. The first stage to healing is removing the damaged bone. And so it's going to resorb the fractured trabeculae That's where you get your subcortical lucency that you would see on radiographs. And then if you give it proper time to heal, everything will heal up fine, including the chondral fissure. But if you don't give it time to heal, then that joint fluid can go up into that cortical defect through the fissure of the cartilage, and then it can undercut the attempt at healing trabecular bone. That's when things become unstable and fleck off as a loose body, okay? So the long and short of all of this is, if you are a high-level athlete and you're having chronic pain, you probably have to stop being a high-level athlete for a while in order to let the body actually heal itself, right? So, okay, we're gonna move on now. We're gonna go down to the spine. I'm sorry, I just noticed that there's a couple of chats. Okay. Okay. I think
It's just to encourage participants to ask, put their questions in the chat box if they have any.
yes. Okay, thank you. I don't think that we have a camera for me, so I'm just going to remain anonymous as far as my face goes, and I'm just the talking voice out of the computer, the way the setup is here. So, but thank you for pointing that out, and we maybe try and make that a little bit better next time. We're moving to the spine. And so we have a football player. This is American football, not international football, or what we like to call soccer. So this is an American football player. So big shoulder pads and helmet, and chronic lower back pain worsening during the football season. X-rays are called normal of the lumbar spine. And so now we have a spine MRI. And who wants to take this? Go ahead. Me? Yeah, that's all right. I'm helping guide. So this is everybody gets a chance. Everyone gets a chance here.
Looks like there's 3 sagittal views of the lumbar spine, the T2 weighted.
Great.
It looks like there's some T2 signal along the anterior aspect of the vertebral bodies.
Okay.
From L2 to L5.
Okay. How about in the bone itself? Okay. How about in this area?
So there's T2 carotid signal, which could represent edema.
Okay. Yep, good. So in still snapshots, it's hard to know exactly what part we're looking at. There is signal anterior to the vertebral bodies that is probably just related to the vessels. So I'm not worried about that, but you'd figure that out if you could scroll through it actively. Background marrow signal is mostly kind of dark, and this is a T2 with fat saturation, so that makes sense. Most marrow within an otherwise healthy adolescent or adult is going to be mostly fatty marrow. Excuse me. If it was really bright, you might worry about some infiltrative process. If it was diffusely bright on a T2 or dark on a T1, you might think about hematopoietic marrow. Some high-level athletes training at high altitudes, for example, would have a lot of hematopoietic marrow just because of the physiologic strain of high-level training with high altitudes, and it's going to demand more oxygen. So you can have reasons for normal bright signal in the marrow in a healthy adolescent. But for your standard near sea level, otherwise healthy adolescent or adult, you should have mostly fatty marrow. So then that means that on this T2-weighted sequence, the signal that we see right here at the L3 pedicle and kind of superior facet is going to be something abnormal. And can you think of anything that would be causing stress in the posterior elements of a lumbar spine athlete?
Something like ligamentous injury.
It's going to be more of a chronic stress, and so we're gonna go back to our verbiage of the OCD. If I say that there's a chronic shearing injury at the osteochondral interface of a joint, and that under the bony cortex, we're going to get trabecular microfracturing, right? There's going to be kind of a torsional strain at the trabeculae right under the bony cortex. So what happens? That it's going to first show as edema because there is stress there. The trabeculae are going to fracture. And then ultimately, if we give it time and keep injuring, then the trabeculae are going to get resorbed and it's going to become lucent and there's going to be a defect there. Okay, so now if I tell you we have a similar process here, this is an American football player who's on the line, constantly pushing up against other players with all of their strength at their lower and upper extremities. And all of that strain is coming down here as they're kind of extending and hyperextending their lumbar spine. And it's getting put right on the posterior elements at L3. This can happen at L4, most commonly L5. So this is basically a spondylolysis process in the course of development, okay? So you have repetitive stress injuries of the posterior elements, and if they don't stop, then they will go on to trabecular microfracturing, bony resorption, and then ultimately a pars defect that will go through the pars interarticularis on whichever side has this stress injury. This is usually bilateral. It's often asymmetric on one side, worse on one side than the other, but it's usually going to show you stress edema on both sides. Now, just like with that femur fracture that I showed you at the very beginning, the femur stress fracture from the high-level University of Chicago athlete, they did a bone scan. They used to do bone scans for this too, as recently as when I was a trainee. So 10-ish years ago, we still occasionally would do a bone scan for this. And they might do it as a standard planar scan imaging, but they might also put them in and do cross-sectional imaging for scintigraphy. And so you can imagine if you had a stress injury at the pars interarticularis and pedicle, and you put them in for a bone scan, just like we see edema here on the MRI, you would see increased uptake on the bone scan. So you'd have a dark spot there. And that's because of that increased bony turnover, the process of the body trying to heal that trabecular microfracturing, osteolysis, and then osteoblastic activity to kind of build things back up, okay? So depending upon what phase you find this injury, you might see nothing on a radiograph and nothing on a CT and only some MRI evident edema. Or you might see, because we don't really do bone scans for that very often anymore here. We now do mostly MRI. So you might just see edema like this, and then if they stop, the edema can go away and they'll never develop a pars defect. Or you might see them continuing their activity. You might see this evolve to a pars defect. And on the CT, you might see a lucent defect and sclerosis at the margins of that defect, okay? If it isn't a full pars defect, if we did a CT at the exact same time as this MRI, you might see a little bit of bony sclerosis in that area without a lucent pars defect, okay? So again, this is a dynamic process of repetitive stress, trabecular microfracturing, the body trying to heal it, with the first stage of healing being first to resorb that broken, ruined bone on a microscopic level, right? That's where the trabeculae are getting rebuilt. And then over time, it will build up, it can become sclerotic, and then it can evolve to totally normal. Or it can go on to a pars defect, and if it does that, then you can go on to listhesis, anterolisthesis, and degenerative changes at the disc at the level below, right? And so this is a very dynamic process. So there are sometimes you'll see in some textbooks, it'll say pars defects are a congenital thing. In my observation and my understanding, that is not true. That is from many, many, many years ago when we didn't have this full dynamic process shown over and over with multimodality imaging, okay? Pars defects not typically a congenital thing. It's a developmental repetitive stress injury, okay? And you can imagine that in combination with the obesity epidemic, with suboptimal nutrition, with inadequate exercise routines, that people are going to be at risk of that type of an injury pattern, especially when they're kind of what we would refer to as weekend warriors, but they're overweight, out of condition, right? So we see that quite a bit. All right, another spine case, an 18-year-old female soccer player, weeks of lower back pain, radiating down the leg, and now she's walking sideways. Her x-rays are normal. So, spine MRI. Oh yeah, I guess you're right. We should go to the next. All right.
Hey, Prof. Swenson, please, we can't hear the person very well.
Yeah, I'm gonna ask them to speak up, and then I'm gonna make sure that I repeat their observations a little bit louder. So,
All right, thank you very much.
Yep, thank you.
There appears to be some mild central canal stimulation. I'd say at the L4, L5 level, with some posterior disc herniation.
Perfect. So we're saying that at the L4, L5 level, we see some disc desiccation. It's dried out a little bit, so it's brighter at the levels above, nice and squishy. And so there's some disc desiccation. There's a disc herniation, or we might say it's protrusion, and there's narrowing of the central canal. So this is, is this a chronic repetitive stress injury, overuse injury? Well, in some ways, right? You can have acute disc herniations, but clearly that disc is not healthy. It's already desiccated, right? The chronic nature of this is often that the annulus fibrosis is a little bit injured. There can be annular fissures, and then some event happens where the disc material actually herniates, right? And then over time, if you give this time, often that disc material, which starts off as fairly water, high water content, kind of juicy disc material, will over time desiccate further and get better and retract a little bit. But in times, it can also get worse. All right, so this is just a standard disc herniation. But I have it in the lecture because it's also relevant that in children and adolescents, in adults, we often say that these don't correlate well with radicular symptoms, but in children, they tend to. In children, spine MRI, if you have a disc herniation, it's usually relevant, and it's usually the direct source of the patient's symptoms and the reason they came in, as opposed to many adult spines where they have multi-level degenerative changes, and it's hard to localize what finding in an adult spine MRI is the source of the actual symptoms. In most adolescents, it's a straightforward, there's the finding, that's the reason they were there for imaging, and it gives you an actionable plan. Okay? Okay, we're moving to the hip. And for the sake of time, and because we're having a little hard time hearing, I'm just going to go through these cases a little bit faster, speaking directly into the microphone. So that means that everyone else in my lecture here is getting off a little bit easy, which isn't very fair, but that's just life. So here we have a 12-year-old male cross-country runner, chronic bilateral hip pain, left worse than right, x-rays normal, and a hip MRI is performed. And here we see that there's an effusion. This is not an arthrogram. So this is the patient's effusion within the left hip joint. The marrow has a nice normal signal to it mostly. And it may be a little hard to see this projecting on a screen, but there's this kind of intermediate signal stuff in the joint as well. At this right here, it's kind of a globular point. There's some frond-like projections here as well, intermediate signal material with kind of frond-like or bubbly projections. And so this is a classic example of synovitis, okay? Now, I actually read this study, and I was worried that this patient would have an inflammatory arthropathy, like a juvenile idiopathic arthritis, because that is a very aggressive synovitis for a patient's joint. It turned out that they had a full rheumatologic workup. Everything was negative. They told him to stop running, and about 3 or 4 months later, they repeated the hip MRI, and the effusion was almost gone, and the synovial proliferation was nearly resolved. So this is a rare example of a synovitis that is specifically related to overuse and stress within the joint. It can happen. It's quite rare. There's not really a surgery thing for this. You can have proliferative situations, PVNS and others, where you have synovial thickening where you would do surgery, but that's a different thing. This was a self-resolving synovitis that apparently was because of this very high-level running athlete who was only like 12 years old. So I just found that to be fascinating. All right, a 21-year-old female athlete, right hip pain, popping sensation for 6 months, x-rays are normal, hip MRI is performed, there are normal x-rays, here's our MRI, and you can see here, this is the femoral neck, anteriorly here at the anterior margin of the acetabulum, the labrum is bright signal, and both the oblique and the axial views, and this is a labral tear going right through the base of the labrum at the osteolabral interface and then into the substance of the labrum itself, okay? So labral tears in athletes, typically a combination of chronic repetitive and then an acute event, all right? So they're gonna have some degenerative process going on or maybe micro tearing that would be below the resolution of MRI. And then often something will happen where they go through an extreme range of motion and that will cause an acute tear that then gives them the real symptoms that bring them in for imaging, okay? And we won't get into the morphologic features of the hip, which is like its whole talk for an hour in and of itself, if we were to get into femoral acetabular impingement. But the long and short is, if we go back to this right here, some patients, their acetabulum is going to cover and actually overcover the femoral head, so it would come down farther. And that can be one based on just the bony morphology of the anterior and lateral acetabulum. It can also be based on the rotation of the bony pelvis, okay? So the more lordotic they are, the way the bony pelvis is angulated, the more coverage anteriorly and laterally the femoral head will have, okay? So if they're too covered by the acetabulum, that would be pincer impingement, or alternatively, their femoral neck may not have this nice concavity here where it meets the femoral head. It may kind of extend out like this, and that would be what we refer to as a cam type impingement or a cam stock deformity of the femoral head neck junction. And that can lead to impingement as well. But the long and short is when patients have impingement of the bony acetabular rim with the femoral neck, then the structure that's getting crunched in between is the labrum, right? And so that's why they tend to get labral degeneration and tearing. Okay, so what do we do for that? Typically, this is, for a discrete labral tear, they may heal with rest, but often if they have bony morphology that needs to be corrected because of their activity, they may go in and try and do a little bit of surgery to give a little bit greater range of motion before they are impinging on the labrum. Okay, questions? All right, we're going to move down to the knee. This is a 21-year-old female, chronic knee pain, x-rays normal, MRI is performed. I know 21 is not pediatric, but as I age, the age of pediatric goes up. And so I consider very much 21 to now be pediatric, and I consider many of my residents in the audience effectively to be pediatric. And so that's just the way it is for me. That's my subjective experience of what it means to be pediatric. And so here we have fragmentation at the lower pole of the patella. And this is commonly referred to as, this is not an acute fracture. This is typically a chronic repetitive injury or avulsive injury at the lower pole of the patella. And on the MRI, you can see that there's fluid within that synchondrosis. There's edema within the main patella and the ossicle. And you can see there's a lot of edema here at the proximal patellar tendon. So there's tendinopathy and probably some tearing. And this is almost certainly a chronic injury superimposed on an acute injury. Okay. And so this is sometimes referred to as jumper's knee or Sinning-Larsen-Johansson syndrome. But the long and short is, this is where the periosteal sleeve, and I'm going to go back here, the quadriceps tendon inserts on the upper pole patella. It becomes an aponeurosis combined with periosteum, and then it concentrates as the patellar tendon. And the periosteum then is going to loop up back here to where the articular surface of the patella starts. And so that is the periosteal sleeve, the quadriceps tendon, the periosteum, and aponeurosis. Periosteum goes up here to the inferior articular surface, and then the patellar tendon. So when the largest muscle group, quadriceps, in the body is pulling on the patella during contraction, there's a high level of stress or strain that occurs at the lower pole of the patella, and the patients can frequently get tiny avulsive injuries or traction injuries down there. And sometimes those evolve as just a tiny avulsion that then heals into normal. But in some cases, as with this one, it heals chronically with basically what amounts to a fibrous coalition between the underlying parent bone and the chronically avulsed ossicle. Okay. Case number 2 of the knee, 12-year-old male, multi-sport athlete. And this is on the same theme. He's got bilateral pain. And I don't know how well this projects, but there's a tiny bony sliver right here. That's an acute bony avulsion. And then over here, there's not an obvious avulsion, but you can see how thick those soft tissues are, right? So this is patellar tendinopathy with an acute avulsion on one side. And I think, frankly, if I were to blow this up and magnify it, I can see it, but I don't know that anyone in the audience here can see it, either on site or remote. But there's a little bit of cortical thickening right here that is probably a healing older avulsion, okay? And so when you have injuries of avulsive nature at the lower pole patella, we call that jumper's knee or Sinning-Larsen-Johansson. When it happens at the tibial tubercle, it's either an acute avulsion or what's referred to as Osgood-Schlatter disease, if it's chronic and repetitive and results in bony fragmentation. Okay. We're going to skip by to the next one. A 19-year-old female, knee pain, stiffness, x-rays normal, MRI performed. You can see that her patella is high, right? So if we were to do the insult-Salvati ratio, the height of the patella to the height of the patellar tendon, that's going to be greater than 1.5 there. For her, it's 1.7. Some people say greater than 1.2 is abnormal. I think that's maybe a little bit aggressive. But long and short is this patella is too high. And so people with patella alta are going to be at risk of some degree of patellar tracking issues. And so that is what we have here. You can see that the patella is laterally tilted and subluxed a little bit on these axial views. And you can see that if we were to do what we refer to as the tibial tuberosity to trochlear groove distance from here out to here, that's probably going to be abnormally elevated. it's 2.2 centimeters, and we think of 1.5 centimeters as being the normal upper limit. And so here you have a patella that is chronically kind of impinging on or crunching on the fat pad. So this is the lateral prefemoral fat pad, and this is the superlateral aspect of Hoffa's fat pad. And this is a chronic patellar tracking issue with fat pad impingement. And that's why she has pain. Okay. Just got a couple more minutes. We're going to wrap up with the ankle, and then we'll do questions. This is a 13-year-old male basketball player, right ankle pain, x-rays demonstrated an abnormality. And this is an osteochondral injury of the talar dome. And as we've now seen one in the elbow, we saw a couple of them in the elbow, right? These can happen in the knee. I don't have an example of that in this lecture, but most commonly we probably talk about them in the knee. And then this one is at the talar dome, all right? And so this again is a chronic, repetitive kind of shearing stress injury at the osteochondral interface of a pediatric joint. And again, what's the first stage? The first stage is a chondral fissure. And then you have subcortical trabecular microfracturing, again, because of the kind of repetitive shearing and torsional strain at the trabecular interface. And then the body wants to heal those trabeculae, so it starts by resorbing them. So then you have a cortical bone with underlying lucency, and that's exactly what we see here, okay? So you've got this cortical bone, underlying lucency. There's gonna be a chondral fissure if you do an MRI. It may be that it's healing by the time you do the MRI, but the source of it is the chondral fissuring that's going to give you problems. So here's our MRI, and you can see that there's this osteochondral injury, bony cortex. Underlying is kind of bright signal that goes along with the lucent segment proportion on the x-rays, and then the overlying cartilage right there. And to wrap up the last couple of weeks, this is a 14-year-old female, 6 weeks of pain. This right here is probably easiest to see on the sagittals, okay? You can see that there's a bunch of bright signal here. You can see it looks like tiny microcystic change. And this is a tarsal coalition, kind of a classic age. So tarsal coalitions occur, become relevant once the patient is getting to skeletal maturity. When they're young, the bones of the foot are mostly cartilage, and cartilage is a little squishy. And so there's a little bit more give with walking, running, jumping, whatever. Once the bones start to fully fill out the cartilaginous omlog, then right as they're getting to that bone, to what is a cartilaginous bridge between what otherwise would be normal bones with a joint, now the bone is getting closer and closer, and all of that torsional and stress and shearing stress is happening at a smaller and smaller interface. That's why they start to develop the symptoms, okay? So they get cartilaginous microfracturing, and they have some evolution. Sometimes they'll have a full bony bridge or a full bony tarsal coalition. Other times that chronic stress will lead to what effectively is a combination of cartilage and fibrous tissue and scarring, okay? But that's why they tend to present at that sort of 12 to 14-year-old age range with tarsal coalitions, because that's when the bones are getting to maturity and you're getting that increased stress at a smaller and smaller spot, okay? And I believe this is the last case, 11-year-old female dancer, 1 month of right-sided foot pain, questioning a navicular stress injury. And I'm just going to put this out to the audience. Is there anyone in the audience that notices a problem here? I'm seeing a few nodding heads. Anybody want to venture a guess at the problem here? These are T2 weighted fat suppressed sequences. And I'll tell you that this is not a ballet dancer who lives at high altitude. And this is not a ballet dancer who has inflammatory bowel disease or Crohn's disease and is therefore has an anemia of chronic disease or iron deficiency. And therefore the marrow signal here probably should not be dismissed as either physiologic stress or hematopoietic marrow because of anemia. So with those leading statements, does anyone think there might be a problem with the marrow signal in this 12-year-old with T2 fat saturated sequences? I'm seeing some nodding heads. They're following my leading questions, all right? So the problem here is that there is diffuse bright signal on a T2 weighted sequence in every visualized bone in the ankle and foot and lower leg, right? So in the tibia, the fibula, and all of these bones. Everywhere, it's too bright, okay? So this is a good example of diffuse marrow signal abnormality in an adolescent extremity. And this is totally abnormal, but one of the scary things is that this is often not observed because of the diffuseness or homogeneity of the marrow signal. And so this should raise alarm bells for an infiltrative process, specifically leukemia, lymphoma, or severe anemia for some reason, or a severe nutrition deficiency where you could, frankly, I've had one case of scurvy that presented kind of like this. So there's a variety of reasons, but what this definitely signals is that there is diffuse infiltrative abnormality of the marrow space. And this patient happened to have leukemia. And I have a handful of cases of young patients who present with MSK symptoms because they have leukemia. And I have 2 cases where the marrow signal abnormality preceded the laboratory abnormalities and the clinical presentation in the acute leukemic setting by months. And this is one of them. So they did labs. The CBC was basically normal within the range of what was considered okay. And it was a few months later that the patient came in leukemic crisis. The repeat CBC was grossly abnormal. And so the way I think of this is, even though it's extremely rare, you basically have your hematopoietic system has numbers of buckets, right? And it's first going to fill up the bucket maybe of the spleen, and then it may go into the marrow, and it may spill over into the peripheral blood at some point later. And so we're clearly not going to be diagnosing leukemia with MRI the vast majority of the time, but it's really important to be aware one of the manifestations of leukemia, lymphoma, or other tumors is that patients will present with musculoskeletal symptoms, and they can be very vague. And so it's good to be comfortable with the marrow signal patterns so that you don't miss that and get a chance to kind of make that diagnosis and get things tracking towards treatment. Okay? So that's the wrap up. We push our kids. We want them to be high-level athletes. We all want Simone Biles as a child. And so we cause them to injure themselves. But hopefully not really. And that's the lecture. So any questions from me?
Thank you very much for a very insightful lecture, Prof. Swenson. We have 2 questions in the chat box. The first one is the difference between jumper's knee versus type 1 bipartite patella.
Yes, thank you for that. So I drive my residents crazy with this topic. So I'm going to go back to that example here. So if there are a handful of very nice papers that describe bipartite patella. And the long and short is this is not a bipartite patella. If you just think about the anatomy, you know that the quadriceps tendon is inserting up here. You know that the patellar tendon is arising down here. And you know that the quadriceps muscle group is the strongest muscle group in the body. So there's a great degree of traction stress or strain going across the patella in everybody, but particularly in young athletes. So when you see fragmentation at the lower pole patella, in my interpretation, I have high degree of confidence in my interpretation, but I'll acknowledge other people may call this bipartite patella. In my interpretation, this is always the result of a traction injury or an avulsion. And when it looks like this and looks like a separate ossicle, it is always because it has been a repetitive chronic traction injury that has led to that ossicle getting bigger and bigger, but not fusing all the way in. And I have a very large number of cases that prove this point with x-rays, with MRI, et cetera. And you can find papers in the literature that make this exact point too. So I'm not really an outlier, but if you go to Keats, for example, Keats, the book of normal variants that mimic disease, excuse me, there will be images like this exact image that will be referred to as bipartite patella. And the reason for that, in my interpretation, is that Keats, while an incredible work of educational effort and research, was published based on case examples that came from decades and decades in the 1900s, most of which preceded MRI, and most of which preceded the modern era of effectively treating patients sooner. And so this patient here, it is conceivable that their knee pain would resolve if they don't do any athletic participation for a while, and that they would then heal to having just fibrous coalition between this ossicle and the underlying patella. But the reason that we see this finding is because there was a chronic repetitive traction or avulsive injury. That's the reason. So it's not normal development, and it's not bipartite patella. It's the result of a traction injury or pathology, but then it can heal to being asymptomatic. Bipartite patella as a normal variant of anatomy is always fragmentation at the superior and lateral aspect of the patella. And we have examples of that, again, throughout the literature, and there's some really good papers that define bipartite patella in that way. So that's my take on that question.
Okay, thank you. The second question is, what would you expect the normal T2 signal to be in this age group? I'm guessing that has to do with the patients with the leukemia. I think that's the last patient you presented.
Right. So this is a good example of what normal marrow should be in an adolescent in the extremities. And so you have a T1 weighted sequence where it's mostly bright and follows the signal of subcutaneous fat. And you have a T2 weighted sequence with fat saturation where, again, it's mostly dark and it follows the fat saturated signal of subcutaneous fat. So that would be the expected marrow signal pattern. When you get down to this ankle, you can see that subcutaneous fat, like here in the calcaneal, in the fat pad of the heel, is dark because this is fat saturated. And up here in the lower leg, subcutaneous fat is dark. But throughout the entire marrow cavity, there's all of this bright signal in every bone that we see. And so that is why it is abnormal. And if we had the T1 weighted sequence for that classically they'll say if the marrow signal on T1, excuse me, is darker than muscle, then that's a bad sign. And I would agree with that, but that would mean that it's so bad that it's that obvious. So often leukemia will present where the T1 will be kind of dark, but it may not necessarily meet the darker than muscle signal criterion. So I would say that that whole T1 signal to muscle comparison would be a very specific finding, but it's not going to be a sensitive finding. So I tend to think of it as a combination of, the sensitivity and specificity. And what I'm looking for marrow is going to be largely based on signal on the T2 weighted sequences for most MSK imaging.
All right, thank you. I also have a question. It's how would you differentiate between reactive synovitis and lipoma arborescens?
Oh, that's a good question. So lipoma arborescens it would be fatty signal on a T1 weighted sequence. I've only ever seen that in the knee. I assume it could happen elsewhere, but I've only seen it in the knee. I've also only seen it in adults. Not to say it couldn't happen in children, but in my experience, I read adult MSK as well on a fairly regular basis, and that's where I've seen lipoma arborescens. So the real trick then is you may see the synovial proliferation on the T2 weighted sequence. Obviously, if you have contrast on board, you'll see that it enhances. But you don't always have a contrast sequence. And so you look for, you want to window the T2 weighted sequence so that you can differentiate between actual synovial fluid and synovial thickening. And then you would compare with the T1 weighted sequence and see if it is largely T1 bright on the T1, then that would say it was a lipoma arborescens type process, as opposed to kind of a more typical primary synovial proliferation.
Thank you very much. Please, are there any further questions? We'll just give you 2 minutes to type your questions if you have any. If not.
In the meantime, hi, David, this is Bhavya Rehani. I don't think we have met. I'm the co-founder and president of Health for the World and professor of neuroradiology at University of Washington. I just wanted to personally thank you for giving such a wonderful lecture. I'm a neuroradiologist, but I still could understand a lot of sports injuries, which you talked about, and I have little kids, so could relate to the stress fractures for sure, But thank you for the excellent lecture. And thank you to Sedinam Damale, who is the chief resident of the radiology residency at Kolibo Teaching Hospital in Ghana, and Dr. Klinam Zefiteti, who is the chair of radiology at Kolibo Teaching Hospital, and all our attendees from different continents who have joined today for this. But thank you, David. This was an excellent lecture. Wanted to personally be here to thank you.
Well, thank you very much. Certainly a pleasure to participate. So thank you for making this happen.
Absolutely. I think we have one more question. Yeah. Sarinam, you go ahead. Yes.
Yes. So the last question we have here is, what is Panner's disease?
Oh, Panner's disease.
Yes.
So this is one of those opportunities where I'm going to acknowledge that while I know the phrase and I know that I would know it if I Googled it, I'm feeling a little stressed because I can't answer it off the top of my head because I don't know which of the diseases. It's an osteochondrosis. Is that the one at the elbow of the capitellum? Yeah, that's a classic pediatric osteochondrosis that I should be able to just spout off the top of my head. So thank you for that stress-inducing question. But acknowledging that I don't always have it all in active hard drive. So I was able to retrieve it. So Panner's disease, if assuming that I'm right, that it is the osteochondrosis of the capitellum. So the way I think of that is younger patient. I sometimes joke, maybe I shouldn't say this, but I'm going to say it, that little children are kind of like salamanders. I remember growing up that if you cut off a salamander's tail, it grows right back. So I think of very young children's bones as being extremely vascular and recoverable. And so what are referred to as the juvenile or pediatric osteochondroses, there are some that happen as patients are getting close to skeletal maturity, for example, 10, 12 years old, like in the hip, we call it, oh dear, now I'm really blanking. Help me out, hip, osteonecrosis of the hip, AVN. Thank you, my resident helped me, leg calviperthes, right? That one, because it's near skeletal maturity and the ossification center is nearly full of bone, those ones will actually be osteonecrosis that then will evolve towards collapsing on itself and sclerosis and then cartilage collapse and joint problems. But when you have a much younger child, like 3, 4, 5, 6, when they develop osteonecrosis of an ossification center, for example, in the capitellum or in the navicular bone or in the femoral head, it almost always resorbs and then becomes sclerotic over the course of a few weeks to months, and then it reconstitutes to completely normal. I've never seen one of those cases go on to have collapse of the bone or articular problems. They always heal to normal, and that's why I think of it as salamander, right? So it's a tiny ossification center in what is otherwise a relatively large cartilaginous onlog, and it probably does undergo osteonecrosis, but because they're so young and so vascularized, it always heals itself to normal, and so it doesn't have any clinical negative outcome. And so they're referred to as osteochondroses. I don't like that term because it's so vague, and I also don't typically, I try to remove named things like Panner's because I'm trying to think of it as like, what is the pathophysiology of that entity? And usually it happens in other places too. So I think of Panner's disease in the same way as I think of Kohler in the navicular, or there's another one that we call it if it's in the femoral head. It is osteonecrosis, in my opinion, of that ossification center, but because they're so young, it will heal to completely normal. As opposed to what we talked about, the capitellar OCD, that's in an adolescent who's basically approaching skeletal maturity. And those ones will often go in, those are repetitive stress injuries that will go on to injury and hurting the joint. So. And I love Google.
All right. We love Google too. Thank you very much for a wonderful lecture. We have learned a lot. We've learned that 45% of, it's just 45% of overuse injuries that are reported. So with this lecture, we hope to report these injuries adequately. We have also learned that if a radiograph is unremarkable, we should still go ahead and then request an MRI because there may be an acute injury that's not visible on the X-ray. Prof. Swenson, thank you very much for giving us this lecture. We are grateful.
Thank you so much.
Thank you so much, Dr. David Swenson. Really appreciate it. Thank you everyone for joining today.